All right, good morning, everybody. I have just about 11 o'clock, so I think we'll go ahead and get started. Welcome to the August HIN office hours. My name is Stacy Klinker. I'm the project manager here at IHC. And today we're going to be hearing from Stacy McSwine and Elizabeth Wick. But before we get started, we'll just take care of a couple housekeeping items. First of all, I'd love to find out who's in the room today. So if you could type your name, facility, and role into the chat box, we can get a better understanding of who's here with us today. Also, please take a moment to mute your phones so we can eliminate any background noise from coming into the presentation today. Also, a reminder that if you have dialed in, please do not place the call on hold, as we will hear your lovely hold music being played during the presentation. Also, I do want to emphasize that we really do encourage question and discussions. So if at any point during the presentation you have a question or a comment, please type that in the chat box and we will have staff moderating that throughout the event. Great. It's great to have you all with us today. Okay, and with that, today we're going to be hearing about Improving Surgical Care and Recovery, a collaborative program to enhance the recovery of surgical patients. Our presenters today are Dr. Elizabeth Wick and Stacy McSwine. Stacy McSwine is an enrollment project manager at the American College of Surgeons. She's responsible for recruitment and enrollment activities for the Agency for Healthcare Research and Quality Safety Program for enhanced recovery after surgery. Stacy previously worked on the ACS National Surgical Quality Improvement Program Business Operations Team and managed the ACS NSQIP Hospital Compare project. Dr. Elizabeth Wick is a colorectal surgeon with an active surgical practice. From frontline clinical care to research, program implementation, and quality measurement, Dr. Wick has contributed to almost every phase of improving perioperative care. Dr. Wick is particularly interested in the role of teamwork, communication, and transdisciplinary collaboration in improving surgical outcomes. She's the co-principal investigator for the Agency for Healthcare Research and Quality Safety Program for enhanced recovery after surgery. With that, I will turn it over to our presenters.
Thank you so much. We're excited to share this program with you guys today and hope that we'll see some Iowa and Midwest hospitals participate. It's called the AHRQ Safety Program for Improving Surgical Care and Recovery, but in its short life, it's had multiple other names. So it's also been called CUSP for ERAS and the AHRQ Safety Program for ERAS, but this is the final name. So if you've heard other things, this is all the same program. And it's a collaboration between the American College of Surgeons, Johns Hopkins Armstrong Institute for Patient Safety and Quality, and really AHRQ, who's funding it and has a strong role in it. And it falls in their portfolio of other large-scale collaboratives they've done around other harms. It's obviously a little different in the past, but its predecessors include the CLABC collaborative, CAUTI, VAP, CUSP, amongst others. But this program is new and exciting, and we really think it's tapping on the best of the best from the past to bring it all together for our perioperative patients. And it's really focused on developing clinical pathways that incorporate all the best evidence for a subset of procedures, some key surgical procedures over the next 5 years, with the goal of really delivering evidence-based perioperative care consistently to all our patients and reducing variability. And some of the pillars that are behind these pathways and themes include all the best evidence for VTE, SSI, and CAUTI prevention. And really the time is right to be working on this because the HCPAC guidelines just came out. The ACS just published SSI guidelines as well. And the CAUTI collaborative is done, and we know what the bundle should be. So all those elements are here, right, to be put in a pathway. Another component is state-of-the-art analgesia and really trying to get away from indiscriminate opioid use and really promoting multimodal analgesia, both to enhance the recovery of our patients, but also help curb the opioid use in the U.S. Early mobility and restoration of functional status, getting our patients up and walking quickly after surgery, helping them get back to what they want to do as quickly as possible. And then avoiding prolonged periods of fasting, both before surgery and after surgery. So letting our patients eat and drink up to a couple hours before surgery, which has been in the guidelines for quite some time, but there's been resistance and trepidation in adopting, and then allowing patients to drink quickly after surgery as well. And all while focusing on patient and family engagement, recognizing that much of this work can't be done with them without thinking of them as partners. Do I control? Next slide. So I think what's different, I sort of started to allude to this in the first slide, is that this is really pulling together a lot of the best in perioperative quality over the past 10 years that's evolved. And so I think really the time is right to do a really complex, big, high impact project like this, because we have the components that have been proven and we know they work. And so this program is really pulling on the power of the ACS Registry and the value of having high quality registry data for complex procedures. The Comprehensive Unit-Based Safety Program is a framework for implementation of quality improvement, and enhanced recovery, which is this idea of a standardized perioperative pathway focusing on early mobility and multimodal pain management and periop nutrition. That's really been popularized in Europe over the past decade, but is in more and more used in the US. So all these things, the evidence is there to support them. We know these things work. They've been used many times before. So what the ISCR program is doing is really pulling all of this together under one umbrella, focusing it on the perioperative area. Next slide. So just for those of you who don't know as much about the ACS Registry, I just wanted to touch on how robust their experience is in registries and data management for surgery. And this program has really taken all the lessons learned from all of their registries. There's the ACS NSQIP registry, which is the one those of us think sort of in this area think of most as a quality improvement registry. And it's a voluntary participation. About 600 or 700 hospitals in the US participate. You get benchmark data. It's really grown over the past decade really quickly. This past summer, the ACS NSQIP Summer Conference had 1,900 people. So really a lot of enthusiasm, developed a community around really valid data. There's also the Trauma Quality Improvement Program, the Bariatric Quality Improvement Program and Registry, Commission on Cancer is run by the ACS, as well as the National Trauma Database. So again, all these things, they have a lot of experience in this space and they're all informing this program. I think the backbone of all their data collection is standardized outcome data definitions, and then for this project we're adding process measures too, because we can't just assume that things that we know should happen are happening. We really need to measure them. And these definitions are all developed by surgeons, nurses, people out there doing the work and continually optimized. And so there's really broad input into these, and I think that's made them extremely useful, valid with our providers that we're feeding back this data to. We know that these registries and the data from them have been effective at supporting hospital quality improvement efforts, as well as informing individual surgeon practice changes with the robust risk adjustment. We also know that the data will allow us to compare and analyze our performance at our hospital, benchmarked against other participating hospitals, which is helpful, and you would get benchmarked process and outcome data to see where you have opportunity and where you may learn from others. Next slide. Then the framework behind all of this is a comprehensive unit-based safety program, and for this program, you're not being asked to start a separate CUSP team. The group that's going to be working at your hospital on implementing this in ISCR and enhanced recovery stuff is going to be the CUSP team. So we just, all the principles of CUSP transferred very nicely to this project. So it's all integrated, it's all one project. But CUSP does have some valuable principles that are going to be incorporated, including really thinking of this at the unit level, not at a hospital level, perioperative level, really thinking about, as we're just doing the colorectal cohort in the first group, how this, having the stakeholders in colorectal surgery, thinking about how this should work and designing it. and then empowering them to resolve the issues and address them and giving them the wherewithal to address them. And then integrating all of this, whether it's through electronic health records or handoff tools or other communications, into our daily work. And then creating a safety partnership between frontline providers and senior executives. We know that that helps a lot, both to show value of this work and align goals, and then also help when there's barriers that the frontline can't address. And finally, there'll be lots of tools on the website available and calls to help you learn from things that aren't doing, learn from others about in areas that you're not performing as well as you might, and learn from defects and help improve safety culture and teamwork, which are the premises of CUSP. So we're excited about another component of this, which has never been in any of the other AHRQ programs, but we're going to have the chance to measure patient experience at the hospital level for patients who are treated on the pathway. And really, it was initially put into the project by AHRQ because they wanted to make sure, as we reduce length of stay and reduce healthcare utilization, we didn't have any negative impact on the patient experience. But actually, I think if you talk to a lot of hospitals that have worked in this area already, one thing is the one thing why it gets so much traction is you get amazing feedback from patients that this is so much better than any surgical care they've had before and things like that. So this is going to be a chance actually not only to make sure we don't have a negative impact, but hopefully to see the positive impact that we have. It'll be measured with a collection of validated questions that are really tailored to the pathway. So there's things that that implementation team is working on and can do. They're all selected from the CAPS question bank, so they're all validated questions. But some of them are from the ambulatory surgery CAPS, and some of them are from the surgery CAPS. And they really have specific questions about your surgeon, anesthesiologist, pain management, things like that. The survey will be mailed to patients by Westat, who is a CAPS contractor and our partner on this project. It all complies with the CMS regulations, and results will be reported back to the hospital directly by Westat. You don't actually have to do anything. All of this happens behind the scenes. So Westat gets the info about mailing the surveys to your patients from ACS, and then you get the report back. So no extra places to enter data. It's all done behind the scenes. Next. Stacey?
Great. I'm happy to have the opportunity to provide you with a brief program overview and then also just discuss some of the many benefits that are available to hospitals who choose to participate in the ISCR. So this new quality improvement initiative is available to all hospitals within the United States, Puerto Rico, and the District of Columbia, and there is no fee to participate. We are anticipating having 5 cohorts that will be structured by surgical specialty, with each of them lasting for 12 months. The first cohort just recently began, and its focus is on colorectal surgery. There is still time for your hospital to participate in that cohort. Additional cohorts will focus on orthopedics, gynecology, emergency general surgery, and bariatrics. Hospitals are eligible to participate in 1 or more cohorts. It's not an all or none type of situation. Now, let me just take a quick moment to discuss who should participate in the program. We know that hospitals with no prior enhanced recovery implementation experience and who are interested in implementing enhanced recovery for colorectal and beyond are definitely candidates to participate in the program. But also hospitals who maybe have attempted to implement enhanced recovery, but due to unforeseen circumstances were unable to sustain their efforts, those hospitals as well are encouraged to participate in the ISCR. Next. So another highlight of this quality improvement initiative is that it is available to both MISCLIP and non-MISCLIP hospitals. Now, in addition to the many benefits associated with participating in the National Surgical Quality Improvement Program, existing MISCLIP hospitals can also expand their efforts to capture compliance with evidence-based perioperative processes. Now, MISCLIP hospitals will also be able to leverage their existing data abstraction resources, and they will also have access to valid and historical data. Now, for hospitals who are not currently enrolled in this CUSP, participation in this quality initiative could help to facilitate quality improvement at your hospital. Now, one of the more exciting benefits is that non-NISCLP hospitals will have access to a dedicated portion of the ACS Registry where your data abstractor can enter a streamlined data set specific for the ISCR program. Non-NISCLP hospitals who are part of a health system where other members are NISCLP participants will have the opportunity to work collaboratively with their member hospitals on this QI initiative. Next. Now, all of the program resources will be accessible and available for download through our program website. Hospitals who participate will, again, have access to enter program data right into the ACS registry. Hospitals will also have access to an implementation guide that is intended to help hospitals integrate the most recent evidence-based practices into their perioperative area. Now, this guide will describe your responsibilities and activities during each phase of the program. It's a great tool that will walk you through month by month as to what you should expect in the activities you should be performing. Now, just one quick note, each cohort does consist of 2 phases, with the first phase focused on prep work and the collection of baseline data that will occur during months 1 through 3. Now, the second phase, which will cover the remaining 9 months of the cohort, will be focused more on implementation and sustainability. Now, the other implementation tools include clinical pathways and teamwork and culture tools, which we will now discuss. Next. Now, the clinical tools that were developed for the ISCR program are more related to technical intervention and will include resources such as up-to-date literature reviews and program-specific pathways developed from evidence review. Now, hospitals will have access to engaging e-learning modules to assist with their local adaptation. Patient education materials, example order sets, pocket guides, and posters will also be available for participating hospitals for each of the cohorts. And now the socio-adaptive tools that were developed for the program are more related to change management. Teamwork and communication will also be available to participating hospitals, including team building tools, because we know that building a strong team is necessary to champion and to lead this type of initiative in your hospital. And with that being said, we are requiring hospitals to identify a surgeon champion, an anesthesia champion, a nurse champion, a resource for data abstraction, and then a program administrator. Now, the program administrator does not need to be an isolated role. It can be combined with one of the first 4 roles we just discussed. There will also be resources and tools available to assist participating hospitals with implementing strategies to manage resistors and sustaining and spreading the pathway. Now, our vision was to meet hospitals where they are and then provide them with necessary support and tools to encourage and facilitate successful implementation of the ISCR program. Next. There will also be opportunities to attend webinars and participate in learning activities throughout each of the cohorts. Perioperative quality experts will lead coaching calls where hospitals can submit questions in advance and then have their questions answered live during those calls. I believe this will facilitate discussion and will also foster a peer learning environment. There will also be periodic content calls where controversial topics around enhanced recovery, such as perioperative glucose management, will be reviewed and discussed by leading experts. Now, participating hospitals will also have an opportunity to participate in both regional and national face-to-face training. Next. There will be a dedicated ISCR clinical support staff who will be available to help hospitals with questions specific to data collection, variable definitions, and any questions regarding the ACS registry. There will also be access to QI implementation support from Deb Hobson, who is our nurse consultant for the ISCR program. The National Project Team will also be available for administrative support as well. Hospitals will also hospitals who have implemented the program will be able to access specific tools and resources and be able to access a sharing library that is available on our website as well. Next.
So the registry, we're excited to have the data collection platform available to both non-NSQIP and NSQIP hospitals. So this is kind of a chance, if you're not a NSQIP hospital, get a taste of the robust data registry. There'll be e-learning modules and tools to help guide in using it. As we said before, there's clinical support, and that's an email away for questions related to the registry or the variables. And the data collection requirement is tied back to the pathway, and the outcomes of interest that are going to be collected are length of stay, readmission, ileus, surgical site infection, VTE, UTI, and mortality. We're also collecting process measures tied back to the pathway, and they include what bowel prep was used and whether or not oral antibiotics were used with the bowel prep, when the Foley was removed, the time of the first VTE prophylaxis administration, the time of whether or not preoperative VTE prophylaxis was used, the time of the first ambulation, and whether or not regional analgesia was used, and whether or not preoperative education was administered. So they really all are things that you need to do to be successful in this pathway. Really, we tried to make it as meaningful as possible. There were lots of people who looked at this to make sure it was as parsimonious as possible.
Next. So now, how can your hospital participate in the ISCR program? Well, the first step is just to send us an email at iscr@facs.org letting us know that you're interested in participating. And next, what we'll do is we will work with you to help you to gather support from key decision makers and stakeholders within your hospital. And then our team will work to help you to fulfill the contractual obligations required for participation. That will include signing a business associate and data usage agreement if your hospital does not already have one on file with the college, and then executing a hospital participation agreement specific for the ISCR program. At that point, you will be ready to schedule an orientation call with our nurse consultant, Deb Hobson. And then we will work with you to confirm your core team members, and then also ask you to confirm who your data abstractor will be. And then you will be ready to start collecting your baseline data for the program. Next. So we thought it would be helpful to just share a few patient quotes from patients who have gone through an enhanced recovery pathway. And one that kind of resonates with me is that every phase of my care was well coordinated, contributing to a very pleasant hospital experience. Next. Thank you all so much for allowing Dr. Wick and myself the opportunity to share additional information regarding the Improving Surgical Care and Recovery program. Just as a quick note, there is still time for your hospital to participate in this program and to participate in our first cohort that is focused on colorectal surgery. Stacy, we're happy to open up the call now for questions if you choose.
Great. I will go ahead and unmute all of the lines. If anybody does have any questions, you can either speak up on the line or type it into the chat, whichever works for you. Okay, and I'm not seeing any questions coming into the chat at this time. Here is the contact information if you do think of questions as you go along. I want to thank our presenters so much for this presentation today, and hopefully we can see some Compass 10 hospitals participating in the project. I also have just a few reminders for things coming up this next month. First of all, our Compass and Learning Community is Tuesday, September 26th at the FFA building on Ankeny's DMAC campus. Some of our topics are going to include interrupting the sepsis process with early detection and intervention, using maps to visualize sepsis data and explore social determinants of health, understanding sepsis-related readmissions, and there will be a review of the Lean application series projects that were completed. Also, a reminder that our office hours are always the last Wednesday of every month. Topic to be determined for next month. Our Person and Family Engagement COP is going to be held September 14th, and we are going to be looking at PFE metrics in relation to HCAP scores, and kind of looking at under-reporting versus underperforming. Katie Reese is the lead for that group. Our medication safety, we have our last opioid guardianship presentation coming up September 21st. Will be a project wrap-up. If you have any questions or comments about that COP, please direct them to Jennifer Kriegmer. Then we have our Falls Prevention COP, which is the third Tuesday of every month. This September will be featuring a presentation on utilization of patient and family education tools. We will be looking at tools that you can use, particularly those with a teach-back emphasis. We'll also be reviewing some videos that can be used in your hospital to promote patient, family, visitor, volunteer, and employee learning. Then our Readmissions and Care Transitions COP is normally the fourth Tuesday of every month, but we will not be having one in September because it falls on the same day as our learning community. But if you do have questions or comments, the lead for that community practice is Kate Carpenter. And then our hospital-acquired infection COP is the first Tuesday of every month, so that will be next week. And Erin Fillmeyer is our lead for that group. And as always, I would like to remind everybody to head on over to Innovation and join the discussion there. If you haven't already registered, please do so. We have a lot of great resource sharing and conversations happening, and it's just a good tool to be able to utilize. So if you have not already registered, go ahead and click the link there and get signed up. And with that, I think that concludes today's office hours. Thank you all so much for taking the time to be with us, and thank you again to our presenters for that great presentation. Thanks, everybody. Bye.